I'm going to begin by just saying it's a pleasure to be here. I've been on a national mission to rebuild primary care, and I've presented this keynote in 6 other venues. So this is the 7th. I presented it in Boston, Chicago, Baltimore, Florida, Texas, California, and now in New York City. And what I want to do is talk to you face to face as a colleague, as somebody who works with you in primary care about what we need to save primary care. I want to begin, however, with just a moment of reflection. I learned last week that Barbara Starfield had died suddenly. I did not know Barbara Starfield personally, but I knew her through her wonderful work in support of primary care. She was a tireless advocate, a pediatrician who was trained at Hopkins. She became a health services researcher. And to quote Richard Roberts, just a past president of the American Academy of Family Practice, Barbara was a tireless advocate for family medicine and primary care. She reminded us of why we chose to become family doctors, to improve health and make the world a better and fairer place. This really is dedicated to Dr. Starfield, who really helped us all with her tireless support, was an inspiration to all of us. What I really want to talk about in the content section is the promise of primary care. Somewhere along your journey to where you are right now, you decided to become a primary care clinician. And in doing so, you made a promise, if you will, to yourself. It may have happened in elementary school, it may have happened in middle school, it may have happened in college, it may have happened during your medical training, it may have happened in your postgraduate training, but somewhere along that way, you decided that this was the work that you wanted to do, and you, in a way, made a promise to yourself and to your profession. I'm going to talk about that promise today. I'm going to talk about the value that you bring to primary care practice. I want to acknowledge that this has become extraordinarily stressful, and to really declare, as I'm sure all of you have declared, that we've just got to do something to bring primary care back to life. We'll understand why you have committed to do this work, and then we need to get a plan of action going. And this is really, in some ways, a motivational talk, because this is only going to happen if we can collaborate. Rebuilding primary care will depend on the work of the primary care community. It's not going to be the upper levels. It's going to be the rank and file. It's going to be the people like yourselves nationwide and you in this room today. So let's get to work. First of all, let's talk about what primary care has become. And I want to emphasize that our work has become extraordinarily complex. In the 30 years or so that I've been in practice, I've watched this transformation. Those of you that have been in practice less have taken on this world that I've watched evolved. We have moved from a reactive paradigm to a proactive paradigm. We've started to identify diseases in asymptomatic states, and we're moving to an era of hypermanagement. So if you take the big 3, as I call them, hypertension, diabetes, hypercholesterolemia, each of those various conditions in an individual patient can have 2 to 3 metrics to be followed, 2 to 3 medications. And as you know, we have many patients that have all of these things going on simultaneously. In addition, as part of that proactive paradigm, we now have a screening and vaccination agenda. So it's not just influenza vaccine, but it's shingles vaccination, it's pneumonia vaccine, HPV vaccines, and then the routine screening tests that have now been shown to be of value. If you look at the density of our work, the complexity, the inputs and the outputs, and you compare the work of, say, psychiatry to cardiology to primary care, the work that you do on a day-to-day basis is roughly 25% higher than that of a cardiologist. So what you recognize in your day-to-day life has been documented in the literature. In addition, there's this, what I call expectation juggernaut. which is all the people that expect us to do things for them. Now, our patients expect us to do things for them, write them letters. That sort of makes sense. But we've got referral management. We've got leaders who expect us to achieve certain performance goals, God forbid performance. Home care agencies now need us to certify that we've had a face-to-face encounter. We're dealing with formulary changes that change from month to month within a given vendor. And then patients move from vendor to vendor, so it's a chaotic environment. And then all the prior approvals that go along with this, all the documentation that we're supposed to provide. I live this world. I know what it's like. It's extraordinarily chaotic. You spend a lot of your time in work that's not compensated. So if you add up the number of hours that you or I spend in a week that we don't get compensated for, it's a pretty substantial number, 12 to 20 hours, and in some cases, my guess is it's even higher than that. If you look at our income per hour, if you sort of work this all out, those of you in primary care, those of us in primary care, get about half of what those our colleagues get are paid in procedures, surgical procedures, and especially radiology. In fact, less than half. We are paid at a lower rate, we work hours, and we're not compensated for it. We're dealing with an extraordinary level of demands. Your work hours are roughly the same as your colleagues in surgery, gastroenterology, dermatology, less. Your compensation is considerably lower. Average numbers, family practice, around $200,000. Gastroenterology, orthopedic surgery, roughly twice that. And to make it even more painful, diagnostic radiology and dermatology make about twice what you make. The payment per unit for your work is extraordinarily discounted. So if you look at a 25-minute cognitive or procedural act, so we look on the left there, we're looking at a primary care visit, a 99214, which is an extended outpatient visit. And you compare the same 25 minutes or so that you do a colonoscopy. In fact, colonoscopies take a lot less time than that. Or a cataract extraction, which in fact takes a lot less than that. The payment per hour, if you look at the CMS payment, $90, $200, $602. It's an extraordinary spread that has evolved in the payment per work unit for primary care versus specialty care. And it's all traceable. You know, you can go back and find out why this is. And I've spent a lot of time trying to figure this out. How did this world get so skewed? Well, we all use the Medicare payment schedule. The indemnities use it. Obviously, Medicare uses it, and most productivity models use it. So, for example, in the Veterans Hospital, productivity is all driven by the Medicare payment schedule, the work RVUs assigned to every little act that goes on in medicine. So that's the payment schedule. It's established by the Center for Medicare and Medicaid Services. But over the last 20 years, this act of assigning value to work has been really controlled by a specialty committee set up by the AMA. 90%, over 90% of all the decisions made by Medicare have been under the influence of a private body sponsored by the AMA. And if you look at the composition of that body, this is it. These are the folks that for the last 20 years have been running the payment schedule. And as you see, 16 specialists and proceduralists. There are 4 primary care types, but in fact the internal medicine representative is an oncologist. So the voice of primary care in this incredibly important advocacy group that has had a powerful influence on payment for physicians is tiny, is small. And as a net consequence of that, over the last 20 years, you've seen these worlds spread apart. So we're underpaid and we're stressed out. If you go and look at survey data for people who practice primary care, 80% cite the chaotic pace of their work life. Burnout levels are extremely high, 20 to 30%. Time pressures are enormous. This is a formal recognition of what you know to be true. And it's not surprising that the residents are not choosing to go into primary care. So this is internal medicine. The figures are pretty much the same in family medicine. And if you look at the last 10 years or so, year by year by year, fewer and fewer residents are choosing to go into primary care. And it's going to be a terrible mess. If you look at the workforce, and you look at the population, and you look at the aging demographics of the population, and you just work the numbers, how many physicians, clinicians, nurse practitioners, primary care providers we're going to need by 2025, and you look at what's actually going to happen if we don't change things, there's a huge spread. The workforce is going to retire, shrink, not be repleted. The need by the public is going to expand, and these two worlds are going to separate. We are facing an immediate, present, enormous crisis, and every one of you knows this to be true. Now here's the sad reality. This has been noted for many, many years. So here's an editorial in the Annals of Internal Medicine, 1993. We hold the view that internal medicine must renew its commitment to generalism and must pursue that commitment aggressively. Robert Petersdorf, he was a huge, powerful figure, a leader, an opinion leader in internal medicine, stating an opinion 28 years ago, hey, you better do something. Kevin Grumbach, he's a family medicine physician in California, in San Francisco, 1999, now 13 years ago. We continue to await the unambiguous arrival of the golden age of primary care in the United States. Hey, we're still waiting. What's happened? And here, one of our colleagues, 3 years ago, Annals of Internal Medicine, The Demise of Primary Care, a diatribe from the trenches. This is the voice of one of your colleagues. This is the voice of somebody just like yourself. Generalists are spending so much time proving that they're good doctors, they don't have time to be good doctors. We're stressed out, and you all know this. So we're talking about promises. Is there a promise for primary care? That's kind of the question here, I think. So in 1897, it was reported that Mark Twain had died. He was traveling in Europe. But, even in those days, things went viral. It was on the telegraph. And so all over the country, word spread, Mark Twain is gone, he's died. Well, Mark Twain heard about this. He was in Europe. He wrote a little note back, and this is actually his note. The report of my death was an exaggeration. So in some ways, your presence here, your attendance here, and all your colleagues throughout the country, because I've talked to literally thousands of people just like yourselves, are proof positive that we are alive. We are very alive. The work you do, the contribution you make is demonstrating that day to day to your patients and to your colleagues. So let's talk about us. Let's take a moment and reflect, if you will, on why you chose primary care. Let's talk about that promise and the commitment that went with that promise. So I'm going to talk about myself. So what guides me? Well, there are mentors. There's one really important mentor, John Stokel. John was an academic primary care physician at the Mass General Hospital. I came there as a resident, and I got to know John. And in knowing John and in watching John and in reading what he wrote, I learned that he was my person. He was who I was. He talked about the doctor-patient relationship as a partnership, And that worked for me. I love the concept of collaboration.